The key thing about these problems is making sure that we get resources to the scene early as possible. One of the problems that they had in Aurora, Colorado, with the shooting is they did not have the resources that they needed as quickly as they needed them. There was a dispatch out, one or two people were shot, and then about 3 minutes into the dispatch, before units had arrived on scene yet, there was a report that the movie theater had been gassed. And at that point in time, that's my clue to say, hey, let me phone a friend, let's get some help in here, because I know that I have a movie theater that's gassed. There's going to be a lot of patients. And they didn't request an additional backup for another 15 minutes or so after that point. So it's hard to get somebody started en route, but once they're started en route, it's easy to cancel. So if you think you're going to need additional resources, go ahead and call them. Don't be afraid. You can always cancel them later. It's better to have too many people on deck than it is to not have enough. Of course, we need to properly stage our vehicles in a way that vehicles can come in and leave without blocking traffic. Typically, it's a good idea when we start staging these vehicles to have them all come into one staging area, and then have a street that we essentially are going to turn into a one-way street, and the ambulances will go up that one-way street and park, pick up their patients, and then continue on that one-way street and then out towards the hospital. Um, we're going to need triage and treatment areas where we have triage officers and treatment officers that are going to take care of these patients. We need to be able to provide effective care. Sometimes that's not going to be possible because we just may be overwhelmed and we don't have the equipment, but we're going to do the best we can, and we're going to have to prioritize our equipment. We have to know, or in our interventions, we have to know what patients are possibly we can possibly save and what patients we can't possibly save. We don't want to waste our time with somebody who is not breathing, for instance, on a mass casualty incident, who has a pulse. We don't really care. We maybe open the airway, or no pulse rather. We maybe open the airway, see if they start breathing on their own again. But that's a situation where we just move on. I just saw a video recently. It was in Haiti right after the earthquake, and there was an EMS crew that. There was a lady who had an amputation and was septic and wound up going into cardiac arrest. And they worked the code, the paramedics who had volunteered from AMR, and they transported the patient to the local tent hospital. And upon arrival, the doctor basically was like, "What are you doing? Why did you work this? We don't have the resources to handle a critical patient like this, somebody who we just resuscitated. We don't have ventilators, we don't have an ICU, we don't have any of the equipment necessary, and you're wasting valuable resources on somebody who's going to die." This is not somebody who's got like a coxio commortis where we can just defibrillate them and everything be fine. This is somebody who is septic and they need all kinds of care, and we can't provide that in this mass casualty situation. So the doctor was pretty displeased at the waste of resources essentially this patient or this EMS crew provided. Of course, we want to save a life, but in this particular situation, those antibiotics we were using on this woman who was going to die, and these drugs and resources we were going to use on this woman who's going to die could have been better used on individuals who had a much higher chance of success.